Our next speaker is joining us virtually, so we should see him on the screen momentarily. But Dr. Richard Chaisson is a professor of medicine, epidemiology, and international health, and directs the Center for AIDS Research and the Center for Tuberculosis Research at the Johns Hopkins University School of Medicine and Bloomberg School of Public Health in Baltimore, US. He received his MD from UMass Medical School in 1982 and trained in internal medicine, infectious diseases, and epidemiology at the University of California, San Francisco, and San Francisco General Hospital. He was the director of the Johns Hopkins AIDS Service Hospital, or AIDS Service from 1988 to 1989. Still not up on the screen, but he is here, I promise. And the medical director of the Baltimore City Health Department Tuberculosis Control Program from 1991 to 1999. It's not Ali again. Dr. Chaisson is here, I promise. His research interests focuses on tuberculosis and HIV infection, including epidemiology, clinical trials, diagnostics, and population-level interventions. He founded and led the consortium to respond effectively to the AIDS TB epidemic, known as CREATE, and was the inaugural chair of the TB Transformative Science Group of the AIDS Clinical Trials Group, leading the development and implementation of this NIH-funded network's TB clinical trials portfolio. He has led numerous NIH, CDC, and FDA-funded trials of TB and TB-HIV interventions over the past 30 years. He is currently the chief of party for the SMART4TB, a UNAIDS-funded consortium conducting research, capacity strengthening, and policy development to achieve the end of TB goals.
Well, thanks very much for the opportunity to be with you, and I'm sorry that I have to be with you virtually. I had a PhD student exam this morning that I had to be present for, and even though we're far to the south of you, it looks like you're having even lovelier weather than we are, so sorry I wasn't able to be there. I'm going to talk today about some advances in TB treatment and prevention in people living with HIV. Just start with disclosures of my funding and personal stakes. And I'm going to be redundant a bit, just give a couple of epidemiologic points. From the latest WHO Global TB report, just to point out that just under 10% of all TB in the world is thought to be HIV related, so 860,000 cases in 2021, and about 12% of TB deaths are in people living with HIV, so an overrepresentation of people with HIV amongst deaths. I think you've probably seen this and maybe even saw it a little earlier today, but the global incidence of TB is pretty static. There have been no major declines in TB incidence over the last 20 years. And as you know, in 2021, the estimates are that there was an actual increase in TB incidence, although there was a decline in TB case notifications due to the COVID pandemic. And TB mortality is thought to have increased as well in 2021 with 10.5 million deaths. The good news amongst this really terrible news in terms of global TB control is that HIV-related TB cases have declined and have really materially declined over the last 20 years. And TB-related mortality has also declined. But there are still hundreds of thousands of HIV-TB-related deaths each year. I mentioned that there was a downturn in global notifications due to the COVID-19 pandemic, and these reductions in TB case notification and reporting are most pronounced in some of the very high-burden countries, as you would expect. Even in the United States, we saw a decline in TB cases in 2020 and 21. And then an increase last year as the late pandemic to post-pandemic era has hit and case notifications have increased again. And this is the TB mortality. So I wanted to say a couple of words about TB mortality in people with HIV because I think it's seriously underdiagnosed and underdetected and underappreciated. So these are some data yet on published from Sunil Solomon from the YRG Care and Johns Hopkins collaboration in India. And it's a verbal autopsy study of over 1,000 people with HIV who died, and verbal autopsies were performed with family using a validated WHO verbal autopsy tool. And what we can see is that a quarter of the deaths people with HIV in this representative sample from India were caused by tuberculosis. And in fact, half of the people who died reported a history, or their family reported a history of tuberculosis. So there's a big mortality burden amongst people living with HIV. And interestingly, the male-female ratio of TB-related deaths was identical, just 24% in men and 24% in women. A little earlier, my colleague Neil Martinson and his wife Tanvir Omar, who's a pathologist, conducted this interesting study in South Africa where they recruited families of individuals, of adults who died at home and were said to have died of natural causes. That is a quarter of all deaths in South Africa, people who die unattended at home and are reported to have died of natural causes, meaning they weren't shot, hit by a bus, or suffered another traumatic death. And so they asked for consent to do a limited biopsy and bronchoalveolar lavage in these decedents. It turned out that 18% of the initial sample was found later to have diagnosed TB that was being treated, but their families didn't know about it, and it wasn't reported at the time of death. Amongst those who had an unknown cause of death, a third had tuberculosis diagnosed post-mortem on at least one test, and 21% had TB diagnosed on 2 different tests. So a considerable burden of tuberculosis in people who are dying in South Africa, where tuberculosis is the leading cause of death already, known tuberculosis. And amongst this small but non-selected group of people who died in the Northwest province of South Africa, a high burden of undiagnosed TB was found. I mentioned on the previous slide that HIV testing wasn't permitted in this study, but Neil and his colleagues have just done a follow-up to this that was conducted in 2019 and then slightly interrupted for the first few months of 2020, but then continued in the pandemic era. And what they found in this follow-up study where HIV testing was permitted was that tuberculosis was diagnosed in just under 20% of people who died of so-called natural causes. And amongst those with HIV, it was 25% of the deaths were that had TB diagnosed, and a high proportion in those whose HIV status was not able to be determined, and these people likely had HIV as well. So the main point is that there's considerable mortality from HIV-related TB that I think is undetected, and that the estimates that we have from the WHO are probably conservative or underestimates. So we all know that the TB-HIV syndemics are located in sub-Saharan Africa in particular. So in 2018, the UN held a high-level meeting of the General Assembly and set ambitious targets for ending TB by 2030. And some specific goals were laid out. The first being that between 2018 and 2022, so through the end of last year, that 40 million people would be diagnosed and treated for tuberculosis, including children and people with multi-drug resistant TB. Those targets were not met. The 40 million people were not diagnosed. as I'll show you in a minute, providing preventive therapy to 30 million people by 2022, including children, household contacts, and 6 million people living with HIV. We'll talk about those as well. And to increase global investments in TB prevention and care to $13 billion, another target not met, and increased investment in TB research to $2 billion per year. And the only good news is that the TB research investment has now grown to over $1 billion per year, half of what the estimated need is, but a substantial increase from earlier years in the past decade. So I'm going to talk about what's new in TB HIV epidemiology just briefly, and then focus on treatment and prevention, keeping in mind these UN goals. So one thing about TB that has long been known is that in children, rates of TB, incidence of TB in boys and girls are pretty much identical. But in adults, there's a preponderance of TB diagnoses in men, with a ratio that often is around 2 to 1, male to female. There have been many explanations offered over the years, including social determinants of health, smoking, alcohol, and so forth. But over the last few years, there's been a greater interest in trying to understand the biological differences that might lead to differences in TB incidence in men and women, particularly post-puberty changes in TB risk that we see. My daughter, who's an epidemiologist now at the University of Illinois, conducted this study with our team in Brazil, looking at sex differences of tuberculosis in people with HIV in Rio de Janeiro. And what she did is she looked at a cohort of almost 55,000 individuals with HIV in Rio de Janeiro from 2010 to 2016. And it was 2/3 male, 1/3 female. And that within that cohort, there were 30,000 individuals who had incidence HIV diagnosed during that time. The age was similar. Women were more likely to be racial ethnic minorities. They had less education than men overall, and in general were from parts of the city and populations within the city that were considered to be at higher risk for tuberculosis infection. What the study showed overall is that amongst all of the people living with HIV, the incidence of tuberculosis in men was higher than it was in women. And if you look at those who did not receive ART, again, it was higher in men than in women. And if you look at those who did receive antiretroviral therapy, the TB incidence was still higher in men than in women, though women were from populations considered at higher risk for TB infection. No TB infection data were available here, but we have data from another study showing that rates of infection in men and women are actually pretty similar at the time of HIV diagnosis. So if we look at individuals with incident HIV, those 30,000 who were diagnosed with HIV during the course of this study, again, overall, men had higher rates of TB than women. The ratio was 1.4, 1.49. I'm sorry, 1.4 is the ratio. For people with out ART, again, more TB, but more in men than women. For those who started ART, less TB, but more in men than women. And if you look by CD4 count, you still see that the CD4 data, that the rates in men are consistently higher than the rates in women. So there's a lot of research going on now trying to understand these biological differences that don't appear to be explained by baseline infection with tuberculosis, or if anything, women have a higher risk and can't be explained by HIV itself or by CD4 count or antiretroviral therapy. It's just an interesting area and something that we wouldn't necessarily expect to have seen with people with HIV, but this sex difference persists in people with HIV. So moving on to treatment, tuberculosis treatment globally, here are the UN targets, 40 million over this 5-year period. And of course, we don't have the 2022 data yet, but we know we're not going to reach that 40 million target. And the treatment for TB in children is pathetic. Treatment of multi-drug resistant tuberculosis is really underperforming, and MDR TB in children is scandalous. So these targets really have not been achieved. By the way, another UN high-level meeting on tuberculosis will be held this coming September, where all of these targets will be revisited. So what do we have that's new for treatment of TB in people with HIV? So we have 4-month regimens now for adults with drug-susceptible TB, but adults and adolescents. 4-month regimen for some children with drug-susceptible TB, and 6-month regimens for adults and adolescents with MDR and XDR TB. Actually, some really nice progress in the last few years, and the progress has been seen in people with HIV as well as in people with HIV. So for the 4-month regimen for drug-susceptible TB, this is TBTC Study 31, ACTG 5349, and this is the study design. So the control regimen was the standard 4-drug HRZE regimen given for 26 weeks. And there were 2 experimental regimens, a rifapentine-based regimen where rifapentine was given in place of rifampin, a high dose of rifapentine, 1,200 milligrams a day, and treatment was for 17 weeks. And then a second experimental regimen with rifapentine and moxifloxacin substituting for ethambutol. Overall, what the study showed was that the rifapentine-moxi regimen was non-inferior to the standard of care, both in the microbiologically eligible population and the accessible population. You can see the rates, the rate differences, and they're depending on which population you look at, but the microbiologically eligible is the larger population that probably better approximates the truth, and a 1% difference in unsuccessful treatment between the standard of care and the experimental regimen, but well within the non-inferiority margin. The regimen with rifapentine substitution alone with no moxifloxacin, however, was not non-inferior. The recurrence rates were higher. You can see a 3 to 4.5% difference in the unsuccessful treatment rate. So the 4-month rifapentine-moxi regimen is non-inferior, but the rifapentine alone is not. Now, within this study, there were several hundred individuals with HIV who were included, and for the people with HIV, the moxi rifapentine regimen actually performed better than the standard of care, and certainly stayed within the non-inferiority margin. But in fact, people who were treated with the moxi rifapentine regimen had lower rates of unsuccessful treatment than those treated with the control regimen. However, those in the rifapentine only arm did considerably worse. And so again, rifapentine moxi is an effective regimen for people with tuberculosis with or without HIV, and in fact, for people with HIV is better than control, the standard of care. So when these data were published in 2021, shortly afterwards, the World Health Organization issued an amendment to its guidelines, a rapid communication stating that this was acceptable alternative regimen for the treatment of drug-susceptible TB in adolescents and adults. And then some months later, the CDC followed suit and in the US issued its guidelines, making this 4-month regimen an acceptable regimen for adults and adolescents. So what about treating TB in people with HIV? So the overall recommendations, I think everyone's familiar with, that treatment for HIV-related TB should begin within 8 weeks of a diagnosis of HIV-related TB. And I'm talking about treatment of the HIV infection here, the antiretroviral therapy, and 2 weeks for individuals with CD4 counts less than 50. Now, several years ago, the WHO changed its guidelines and recommended that everybody get treatment within 2 weeks, everyone with HIV. The rationale for this is not evidence-based. The evidence suggests that it's better for people with higher CD4 counts to wait because you avoid toxicity such as immune reconstitution syndrome without sacrificing efficacy. The WHO guidelines are more based on programmatic concerns that if you don't start the antiretroviral treatment quickly, people will get lost. But it's not based on evidence that it's clinically better. In fact, we know that it's not clinically better. So what about treating people with a non-nucleoside regimen? This is the regimen for which we still have the most data, and it's the clearest and strongest recommendation. And you can use a rifampin-based regimen or a rifapentine-based regimen with efavirenz. You can also use a rifabutin-based regimen with efavirenz, but there's no reason why you would want to do that. It requires a dose change of the rifabutin, and you can use rifampin or rifapentine just as easily. So there's no rationale for using rifabutin, but you can do it if you want. For integrase inhibitor-based heart regimens, rifampin can be given with dolutegravir, and there are data from the Inspiring study that showed that if you gave dolutegravir twice daily along with a rifampin-based regimen, that you would overcome the drug-drug interaction of rifampin clearing the dolutegravir and reducing exposures. Rifampin can also be given to people getting a raltegravir-based twice-daily regimen. And then for a boosted protease inhibitor regimen, a lopinavir and a rifabutin-based regimen can be used, but in fact, there's now data showing that a double-dose lopinavir, ritonavir with rifampin-based regimen is actually safer. What about the 4-month regimen in high-dose rifapentine? We don't have any data yet on use of dolutegravir with that regimen, but an AIDS clinical trials group study of that is set to begin sometime in the next several months. Recently at the Montreal AIDS conference last year, and then an update presented at CROI this year from Gary Martins and colleagues in Cape Town, looked at individuals with HIV-related TB treated with a standard rifampin-based regimen and compared once daily dolutegravir to twice daily dolutegravir, and showed that virologic suppression was identical in both groups, with over 80% achieving virologic suppression at the end of the 6 months of treatment. Even though there is a clear drug-drug interaction with rifampin reducing dolutegravir exposures. But it turns out that the targets that have been used, the pharmacologic targets that have been used for dolutegravir may not be valid because clearly, even with reduced exposure to dolutegravir, viral suppression was not compromised. So this is not yet a recommendation that anyone has adopted. In fact, the radiant TB data have yet to be published, though they should be published very shortly, I'm told, but they have been presented. And so these are very, very compelling data. What about the short rifapentine-based moxi regimen and treatment with efavirenz? Well, there we know that you can co-administer efavirenz with this regimen, and whether you start with a suppressed viral load and an efavirenz-based regimen, that's the data on the left, or people who don't have a suppressed viral load who begin efavirenz-based ART 8 weeks into their TB therapy, there's no effect of this regimen on exposures to efavirenz. And so this is a safe combination. And as I mentioned, ACTG 5406 will look at dolutegravir twice daily with this, with the HPMZ regimen. Another major advance in the last year or so is the SHINE study, which looked at shorter treatment for non-severe TB in children. So this was a study looking at children under the age of 16, so the median age was 3.5, who had non-severe tuberculosis, presumed mostly or confirmed in a small proportion. And non-severe was defined as not extensive pulmonary involvement, less than only one lobe, no cavities, no miliary TB, so modest TB in children, non-severe. And 11% of the children were HIV positive. And they were randomized to get either a 4-month regimen, basically the standard of care regimen, but stopped after 4 months, versus the 6-month regimen. And the results showed that there were essentially no differences in outcome, and everything trending towards the 4-month regimen being a tad better, but overall no real difference. And so this 4-month regimen for children who do not have severe TB has now been shown to be non-inferior and has been recommended by the WHO as the standard of care for children with non-severe TB. One challenge is that it requires a chest x-ray to stratify the children, and in many parts of the world, chest x-rays still aren't readily available for children diagnosed with TB. And so that remains a challenge with implementing this regimen. What about drug-resistant TB? So there's been really remarkable progress with MDR-TB and XDR-TB over the last couple of years. I mean, just considering where MDR-TB treatment had been before this, it's truly stunning. So you will recall in 2020, Francesca Conradi and her colleagues published the NICS study, and this was a kind of wild study when you think about it, a non-controlled study of a completely novel regimen for XDR-TB or refractory MDR-TB of protomidid, bedaquiline, and linezolid for 6 months. And the rationale for a non-controlled study was that there was no standard of care, and we knew that mortality in XDR-TB or refractory MDR-TB was approximately 80%. So they argued there's no control regimen to study. And what they found was that this 6-month all-oral regimen was highly successful with 90% favorable outcomes overall. Most of the deaths that occurred very early from advanced, longstanding, previously untreatable TB, and very few relapses. And results were similar for people with and without HIV. And you can see that adverse events were pretty common, but there were no differences amongst people with and without HIV. The dose of linezolid was associated with some differences in adverse reactions, but not, most striking for the twice daily linezolid regimen. Subsequently, Francesca and her colleagues published the follow-up Xenix study, and in the Xenix study, they randomized individuals with XDR or refractory MDR TB to get the NICS regimen, the BPAL regimen, bedaquiline, protomanid, and linezolid, and they randomized them to different dosings of linezolid and different durations of linezolid. So a high dose of linezolid for 6 months or 2 months, a low dose of linezolid for 6 months or for 2 months. And what they showed was that overall treatment success was very, very good, but the short course of the lower dose of linezolid had poorer performance than the long course of the higher dose regimen. So 93% for the high dose full 6 months versus 84% treatment success for the low dose 2-month regimen. Nonetheless, confirming this is a very potent combination of drugs for TB. And again, results very similar for people with and without HIV. And then more recently, the TB Practical study done by MSF enrolled people. It was a multi-stage study. They randomized them to 3 different BPAL-based regimens, one just BPAL, one where clofazimine was added, and one where moxifloxacin was added, BPALM. And after an interim analysis, they stuck with the BPALM, so where the moxifloxacin was added, and compared this to a control regimen of 36 to 96 weeks. And overall, the primary outcome was unsuccessful treatment, meaning treatment had to be changed, and it was driven almost entirely by adverse events. Again, the study included 3 experimental regimens. I'm just highlighting the BPALM regimen compared to the standard of care. And you can see that in the standard of care regimen, control regimen, almost 50% of patients stopped treatment, but that was driven mostly by adverse events, not by unsuccessful treatment. There were vanishingly few unsuccessful treatments, compared to 11% in the BPALM regimen. And again, people with HIV did equally well with the BPALM regimen as those without HIV. So last May, the WHO issued another rapid communication recommending that the BPALM regimen be considered a first-line regimen for MDR fampin-resistant tuberculosis. And now with implementation, the question is, do we need to do fluoroquinolone susceptibility testing and modify the regimen by dropping the moxifloxacin if there is fluoroquinolone resistance, or should this just be a regimen that is used across the board and the fluoroquinolone susceptibility testing isn't required? So moving on now to preventive therapy and progress in preventive therapy for people with HIV. So I mentioned the WHO, or rather the UN high-level meeting targets, and the target was to treat 30 million people for TB infection with TB preventive therapy. As of the end of 2021, only 42% of that target had been met. Now here, the surprising and good news is that for people with HIV, where the target was 6 million, the target was actually exceeded, and it's estimated that 10 million people were with HIV were given TB preventive therapy between 2018 and 2021. You might argue that that's not a very ambitious target because the real number in need is closer to 30 million. Nevertheless, that is the target that was set, and the good news is it was exceeded. Now, from programmatic data that I have seen in several countries, it's also clear that even though 10 million people may have been started on TB preventive therapy, it's not clear that all of them finished it. But nonetheless, I think this is very encouraging progress. The progress with household contacts is poor, and for children, household contacts over 5 rather, it's practically non-existent. So those are the targets. What about our oops, sorry. Yeah, sorry, here we go. So again, if you see the increase in the number of people who receive TB preventive therapy, you see that the increase is driven largely by people living with HIV. So what are the options? So the 3-month rifapentine isoniazid regimen, or 3HP, is not news, of course, to anyone. These data have been available now for over a decade. But what we know with 3HP is that the 12-week once-weekly regimen of rifapentine and INH is non-inferior or even superior to a control regimen of INH in adults, adolescents, and children down to age 2. It's very effective in people with HIV. Overall, it's safer than isoniazid or rifampin and pyrazinamide, and it has better treatment completion and better adherence. The only reason that it has better adherence and treatment completion is because it's shorter. Practically every study of TB preventive therapy shows that what drives adherence and completion is the length of the regimen. And so these are the data from study 26, the bottom study on the left, rather, that Tim Sterling and I led. And you can see that the rate of treatment discontinuation in the 3HP arm was actually a little higher, but the regimen was done faster, and so fewer people ended up stopping treatment. The longer you have to be on the regimen, the more opportunity you have to stop it. And so the duration of the therapy really drives treatment completion rates. One of the questions for people living with HIV is once enough? Is a single course of 3HP or any preventive regimen adequate? Or people living in high-burden countries, might they benefit from an additional course of preventive therapy? And so this study, the WIP3TB study that was led by Gavin Churchyard, done in Ethiopia, Mozambique, and South Africa, but largely South Africa, randomized individuals to either a control regimen of 6 months of isoniazid or 3HP given once at the beginning of the study, or twice, a second course being given after a year. Now, only a small number of people were randomized to the control arm, and this was for purposes of showing that adherence for the control arm isn't as good as for 3HP, and that was shown that for the people who got 3HP, completion rates were 90%. For people who got 6 months of INH, completion rates were 50%. But in terms of efficacy, a single round of 3HP was equally efficacious to 2 rounds, here called annual rifapentine isoniazid, that is getting it at the beginning of the study and then a year later. And for mortality, actually, you can see that there was a slightly higher mortality rate in individuals who got a second course, but there's no evidence that that was drug-related. But it's clear that doing 2 courses of 3-HP isn't beneficial and isn't necessary, even in these very high burden settings. What about giving a 3-HP with antiretroviral therapy? Well, we know and have known for years that 3-HP can be given with favirenz. But what about dolutegravir? Again, dolutegravir exposure is reduced by rifamycins being co-administered. And so in the Dolphin study, we looked at co-administration of 3-HP with a dolutegravir-based regimen. And what we showed is that there was a reduction in exposure to dolutegravir with co-administration of 3-HP. However, everyone remained virologically suppressed throughout the study, although after the 3-HP was completed, one individual did have a rebound, but this was returned to she returned to undetectable with adherence counseling. So 3-HP and dolutegravir-based ART can be co-administered. And more evidence of this came again from my daughter working with a group at Makerere University in Kampala and folks from UCSF, and looked at people in a routine programs setting who received a TLD, the tenofovir, lamivudine, and dolutegravir regimen with or without 3-HP. Now, this was an observational study. It wasn't a randomized trial. And in fact, the study was really of diagnosis of TB in people starting antiretroviral therapy, but they had the opportunity to compare people who got 3-HP. And what they showed is that after 6 months, there was a slightly lower proportion of individuals with a viral load less than 50 copies. You can see a significantly lower proportion. Although for viral load less than 200, the difference wasn't significant. And by 12 months of follow-up, the differences had essentially gone away for less than 200, and still a slightly lower proportion with a viral load less than 50. But programmatic data supporting the use of 3-HP in once daily dolutegravir-based treatment. Several years ago, we published the results of the BRIEF TB study, which looked at 1 month of rifapentine and isoniazid given daily compared to 9 months of isoniazid alone in people living with HIV, and showed that the 1 month regimen, 1-HP, was non-inferior to 9 months of INH. And this was all people living with HIV. Not all of them had a positive TST or IGRA test, but amongst those who did, the 1-HP regimen remained non-inferior to the standard of care. So 1-HP is a regimen that is known to be effective in people with HIV. And there is no impact of favirenz co-administration with 1-HP. So favirenz can be safely given. What about integrase inhibitors? Well, this study from Taiwan looked at the 1-HP regimen given to people who were being treated with bictegravir, the Biktarvy single dose or fixed dose combination. And what they showed is that there was an effect of co-administration of 1-HP with bictegravir-based regimen in viral suppression at 15 days, and a very modest effect at 30 days. But at 3 and 6 months, all individuals were successfully suppressed on their bictegravir-based regimen, again suggesting that once a once daily integrase inhibitor can be co-administered with the 1-HP regimen. The ACTG has been looking at this with dolutegravir, and in this study that was presented at CROI last year, they looked at twice daily dosing of dolutegravir with the 1 HP regimen. The schema is shown here. And what they found was that at baseline dolutegravir PK was, as you would expect, well above the target trough concentration. And then over time, with twice daily dosing, trough concentrations remained high. And you can see in the last panel at week 4 where they did intensive PK, that over time, giving that second daily dose restored levels to very supratherapeutic levels for viral suppression. So this team is now moving on and will be looking at once daily dolutegravir dosing. And based on the results that we saw from the RADIANT study for treatment of active TB, the anticipation is that that will be a safe study to conduct, and the hope is that once daily dosing of dolutegravir will be sufficient with co-administration of 1 HP. So just to wrap up in the last few minutes, I want to just ask, are we there yet? We've gone from a year of INH preventive therapy when I was in training to 9 months, 20 years ago, down to 6 months out of pragmatism, 4 months with a rifampin-based regimen, 3 months with 3 HP, and now 1 month with 1 HP. And can we do better? I'm going to show you these data from Eric Nürnberger and Jacques Rosset from their mouse model of latent TB. And these are the data that led to the brief TB study, the 1 HP study, showing that a regimen of 1 HP significantly reduces lung concentrations of mycobacteria in the mouse model. And this now was validated that the 1 HP regimen was effective. This is what 1 month of bedaquiline does. So 1 month of bedaquiline is the same as 1 month of rifapentine and INH. And that might be a pan-TB regimen that could be useful for drug-resistant TB, as well as drug-susceptible TB. If you add rifapentine to bedaquiline, J stands for bedaquiline, that's it's a Janssen drug, it's even more potent, and if you add PZA to that, it's even more potent. Now, bedaquiline and rifapentine can't be co-administered in humans, even though it can in mice. So a 1 month regimen of bedaquiline is a very attractive regimen to be a pan-TB regimen. But data that Eric Nürnberger and his team have shown in mice with an injectable form of bedaquiline, a long-acting injectable form, show that therapeutic concentrations of bedaquiline persist for 3 months after a single injection in mice. And you can see that the MIC for MTB is shown in the red dotted line. And the concentrations of bedaquiline and its active metabolite are well above the MIC for up to 3 months after a single IM injection. And this is a study looking at the bacteriologic effects of either a single dose, 2 doses, or 3 doses of bedaquiline in mice over a 3-month period. And all 3 approaches, a single dose, a double dose, or a triple dose, resulted in profound reductions in bedaquiline, in tuberculosis in the lungs, suggesting that this could possibly be an effective long-acting treatment for TB infection. Human formulations of long-acting bedaquiline are in development by Janssen. And then finally, what about a vaccine? you know that the M72 vaccine study, which was conducted in individuals with latent tuberculosis, HIV negative, mostly adolescent and young adults, showed 50% efficacy. And now there's a phase 3 trial that is planned. It's still not clear whether people with HIV will be included in that study. There's a lot of advocacy going on to make sure that that's the case, but it has not yet been decided. But that's another possibility for TB prevention. So in terms of what our current options are, we have a lot of options now. We can use longer courses of isoniazid, and we can co-administer them with antiretroviral therapy. We can use shorter courses of rifampin or rifampin and INH and co-administer with many antiretroviral regimens. 3-HP can be co-administered with efavirenz and dolutegravir or raltegravir. And then 1-HP can be co-administered with efavirenz and dolutegravir and raltegravir, and may be able to be given with once daily. So just to quickly summarize, HIV-related TB is globally important and accounts for a lot of cases and deaths. There are higher rates in men than in women, including in people with HIV. There's been some really remarkable advances in therapeutics with shorter regimens for drug-susceptible TB in adults and children with HIV, and for multi-drug resistant and extensively drug-resistant TB. And now we have lots of options for short course regimens for prevention of TB in people with HIV that can be co-administered with our current ART regimens. And maybe someday in the future, there'll be a one-shot preventive therapy regimen that will be a long-acting injectable. And we'll see how that pans out over the next few years. So with that, I will end, and thank you again very much for the invitation to be with you today.